Welcome everybody to this webinar. This is the last one in a series of 3 webinars. And these webinars with a focus on rare coagulation disorders are a collaboration between the International Society of Laboratory Hematology and the European Reference Network's EuroBloodNet. The main objective of this program is to distribute up-to-date knowledge and give visibility to advances in the field of rare coagulation disorders. In the previous webinars, we addressed factor 11 deficiency and inherited fibrinogen disorders, and the topic of today is hemophilia. All these disorders have significant implications for patient management and treatment, and the aim of these webinars is also to improve patient care. After the presentation, there is a 15-minute Q&A session with the attendees, and you can find the Q&A button at the bottom of your screen. The webinars will be also recorded, and the videos will be integrated into the ISLH ERN-EuroBloodNet e-learning environments. The webinar of today will give us an overview of the treatment options in hemophilia A and B. And it is my pleasure to introduce our speaker, Professor Flora Peyvandi. Professor Peyvandi is Professor of Internal Medicine at the University of Milan and Director of the Hemophilia and Thrombosis Center. She is also head of the Department of Rare Disorders at the Policlinico of Milan, grouping 15 ERNs. Since many years, Professor Peyvandi has been participating in clinical, educational, and research activities of different European and international scientific societies and patient organizations. She is the immediate past president of the International Society of Thrombosis and Hemostasis, and she also serves as advisor on the European Agency of Medicine and on the Technical Health Committee of the Italian Ministry of Health. Her experience is reflected in many publications in the field of hemostasis and thrombosis. So we are very happy today that we have Professor Peyvandi here with us to give the talk on the treatment options of hemophilia A and B. Please, Flora, the floor is yours.
Good afternoon to everyone, and thank you very much, Katrien, for this very kind presentation and introduction. And I want to thank also EuroBloodNet and ISLH for giving this space to rare disorder and particularly to hemophilia A and B. Here are my conflicts. For introduction of hemophilia, I try to spend 2 slides only because I think most of you are familiar with what is a rare bleeding disorder. Usually these are the coagulation disorder, very heterogeneous and caused by deficiency of some proteins in the cascade of the coagulation or dysfunctionality of these proteins, which is leading to alteration of the formation of the clot. This kind of dysfunction are bringing a spontaneous type of bleeding, and the severity of this condition is depend on the extent of the deficiency that we have. The bleeding disorders could be hemophilia A and B from Willebrand-Rey bleeding disorder and platelet defects. And today we are just focusing on factor 8 and factor 9 deficiency, which is about almost 240,000 people around the world registered. And mainly the registration, I would say, is focused on the male cases and is underestimated for the female and for the moderate and mild cases, which I hope in the future we can have a better and more suitable and of course precise data on making the better diagnosis and collecting the better data in the registries. In terms of diagnosis, there are several steps of the personal and family bleeding history which should be collected when a patient have the problem of the bleeding manifestation, and especially if there is no family history in the past, this should be even more concentrated on any type of bleeding manifestation and making a good collection of the bleeding score of patient. Then we are entering to the first level, which PT and APT, and mixing studies showing us whether this is a congenital or it is an acquired type of deficiency. We need to go for the fibrinogen type of test and the second levels, and going finally to the measurement of the levels of the factor. And of course, in hemophilia, we have the reduction of factor 8 and factor 9. But the amount of the plasma factor conserved factor for factor 8 or factor 9 is leading us to make a diagnosis of severe cases, which is consisting to less than 1% of factor level, moderate 1 to 5%, and mild between 5 to 40%. However, there was a lot of, there is ongoing discussion whether this classification still could fit with what is the need in hemophilia, or we have to be much more focused in terms of the clinical manifestation. The prevalence for the severe cases is reported to be about 6 cases for 500,000 males for hemophilia A, and this amount actually is about 5 times more. I do apologize, there is a wrong number here. For hemophilia B is about 5 times less, about 1.1, 1.2. It's not so much wrong, but is about exactly 5 times less compared to hemophilia A. About clinical manifestation. Usually the clinical manifestation in the patient with hemophilia is soft joint bleeding, and especially hemarthrosis and hematoma. But hemarthrosis and recurrent joint bleeding, especially on the target joint, is the most important problem leading to the arthropathies in this patient if it's not treated as it has to be, and early that has to be. So these joint damages could go to the chronic arthropathy disability, which normally in our patients in the past end up to the orthopedic surgery. And this number is getting less and less with a better treatment, with the introduction of prophylaxis in the early stage. And that leads to the acute and the chronic pain, synovitis, and the chronic pain with the usage of the painkiller and some other side effect due to the usage of extensive painkiller for the long time. And the limitations is also in the school work and also the productivity of our patients, and also to the normal activity of our patients, and that ends to have an impact in the psychological sphere of the life of our patient and the quality of the life. So the standard care right now, we know, is the regular prophylaxis, as we said. And in 2007, we had the first randomized clinical trial, which showed the superiority of the prophylaxis. And with that introduction, we had significantly improvement of the quality of life of our patients. We were able, with the usage of standard product for factor 8 and factor 9, both plasma-derived and recombinant, to achieve a trough level of 1 or 2% with recurrent treatment, about 2 to 3 times. And we were not able to increase the protection with the higher levels of trough because of the half-life of our product. Then we had the introduction of novel drugs and new extended half-life products, which allowed us to make the guidelines with 3 to 5% minimum amount of the trough in order to protect the joint of our patients. But these days, we are discussing whether that amount is enough really to have to give to our patient a normal style life, or we need a higher protection. And this higher protection is these days possible with a series of the products that today I have to discuss about that. So the normalization of the hemostasis is allowing probably in future to our patient to have no bleeding, and we are seeing more and more the annual bleeding rate reduction up to 0. And that possibly to conduct us to a no joint deterioration, and we hope to reduce the pain and improve the quality of life of our patient. And you know very well that we had the improvement of products significantly with the recombinant products, with the several type of the recombinant and extended half-life products. And then in 2010, with the introduction of non-replacement therapy, we started a new chapter of treatment. And these days, we have availability to use also the gene therapy in our patients. And soon, I hope, we have the availability of the treatment using the oral treatment. Let's go to see what we have and what are the evidences in terms of the safety and efficacy regarding all these novel drugs. First, with pegylation product and fusion product. These were the first extended half-life products that allowed us to have a longer half-life and reducing the infusion of our patient. Much more for factor 9, because the number of the infusion were significantly reduced by 60% and the trough level by 5 to 10%. So for factor 8, the level of trough level were about 2 to 3% with a reduction of 30%. And even the usage of these drugs, which really significantly improve the quality of our patient, shows that still there are few percent of our patients, about 70% of the patient, that might have breakthrough bleeding. And that's the reason why these days, with the improvement of the therapies, we are thinking that even 1 or 2 bleeding might end up with the problems of synovitis and deterioration of target joints. So that's the reason why we do need even to reduce these numbers. And what are then the burdens of hemophilia these days, and how we have to think about the better quality of life of our patient? Definitely, as I explained, we do not need to have any joint damage. We want to have the life of our patient with a completely normal social life, not social isolation, no pain, and no psychological alteration, and the personal productivity of our patient should be normal and close to the general population. However, the presence of the subclinical bleeding still is bringing some trouble for a portion of our patients in terms of the joint pain, especially the pain issue has not been solved, and still there are percent of the patient are using the painkiller regularly in every center, I would say. So then the focus of every hemophilia center at this stage in the world is how I'm going to make better treatment, optimization of the treatment, but how I can make the early diagnosis. And there are several work these days, at least few hub centers in the world, that are trying to make the detection of early image of bleeding by remote control of ultrasound assessment and trying to make this tool available for the patients. So what we have done in Milan was, first of all, to understand how there is the ultrasound's sensitivity and specificity using the ultrasound, the big ultrasound in our centers, and then using the small one, the one that you can use with a mobile phone, and trying to make it available for the patient. And why that is important? It's important because we made the analysis now, and this data will be available in the ISLH meeting, that every patient before starting the treatment is just spending about 2-3 hours. And it's not easy to have access to a center when they can make an accurate diagnosis. And that's the reason why having availability of this kind of tools is very important in the future. So having a novel remote evaluation system should be the goal in the future. But the second point is what type of drug I should have to make a better protection of my patients. Several products are coming, and we need to understand the efficacy and safety of them. And unfortunately, because of the difficulty, none of these drugs made a comparison head-to-head between them to understand the superiority of these drugs. Each of these drugs has been evaluated in patients compared to what has been used in the past 6 months or 1 year. So that's the reason why it's extremely difficult for us as a physician and for you as a patient to understand which of these drugs is more powerful and is better. That's the reason why we need to have really good collection of the data and understanding them more. Let's go to start. I do apologize in advance because there are lots of them, but I try to make it easy as a concept. The first, factor 8, with a really significant longer acting half-life, is the one is called efanesoctocog alpha. Is a single recombinant factor 8 protein. What is the difference of this molecule compared to the previous one? Is containing D' D3 domain of von Willebrand factor, and that's the reason why it's not depending to the endogenous von Willebrand and is remaining in the circulation for a long time and could be infused only once a week. And the protection of this drug is much longer to what we were used for in the adult. For example, we can see for the 3-4 days, the level is more than 40%. And after 7 days, the levels is becoming about 10% up to 15%. And in children is a little bit less, but all over, I would say this protection is significantly higher with one single weekly infusion compared to what we have used. What in terms of the safety? In terms of the safety, all over, this drug was very successful, showing no important serious side effect. No, the thromboembolic event has been reported in 3 cases out of 206, and it was in line to what we have seen. Transient anti-drug antibodies has been seen in 2.2, which was not associated during the clinical trial with any problem of the functional activity. We need to understand the prevalence of inhibitor development in both groups of patients not previously treated POPs or those that are treated. And that data is very much requested to understand the safety of this product compared to the previous one. So all over, I would say this is a very important product, has been approved by the regulators, and we are looking forward to have it in several countries and to collect the information regarding the safety and efficacy of these drugs. But you know that non-replacement therapy was a big revolution in terms of the treatment of patients. And the first drug was emicizumab, bispecific antibody mimicking factor 8. And after that, there are several other products like concizumab and marstacimab, anti-TFPI, and fitusiran that have been developed. What are the advantages of these products? First of all, they are only for prophylaxis, and they cannot be used during the acute bleeding for the treatment of the acute bleeding. That means when you're using these drugs, you have to have something for the acute bleeding. They can mainly be used for all groups with hemophilia A and B, a part of emicizumab, which is only for hemophilia A, with and without inhibitor. They are easy infusion, subcutaneous infusion. That means the is much easier, and the frequency of infusion is much less compared to what we were used. Once a week, every 2 weeks, once a month, or every 2 months. There is no peak and trough. They have stable protection for our patients, and that's a very important point. And that's the reason why comparison between these different drugs is becoming very important. As I said, they are mimicking The first one, factor VIII, by enhancing coagulation. And emicizumab was the first one that has been approved by both FDA and EMA. And now there are several patients around the world in different countries that are using that. And you can see in this cartoon how elegantly this type of bispecific antibody is binding factor 9A from with one arm, and the second arm is going to get factor 10, and in the membrane, activation of factor 10A, activation of factor 10, and getting the activation of factor 10 to 10A. So at the beginning, there was some worriness about emicizumab, and that was because few cases of thrombotic macroangiopathy has been seen by the high dosage of activated prothrombin complex. And we learned with further experiences that factor 7A in association or the low amount of APCC could be used. And there are several data on the efficacy both in pediatric and in adult, showing that even after the accumulation of the data by Haven 1, 2, 3, 4, that was showing there is 82% of the patient almost have zero bleed. This data has been replicated actually in other type of the cohorts. You can see here, for example, in the UK CDEO with 117 hemophilia A patients in both group of adult and children, and confirming the efficacy of these drugs and also reducing the number of thromboembolic events. However, 3 arterial thrombotic events have been reported, and of those 2 were associated with emicizumab. And in children, of course, the thrombotic event is much less. The problem could be injection site reaction, which usually after 2 or 3 injections is getting less. But in adults, we need to keep an eye, and we keep this good surveillance in the future in terms of the safety and efficacy. The second product is Mimate, is a human IgG bispecific antibody, and in vitro and in vitro and in vivo analysis showed a much higher thrombin generation, about 15 times fold lower concentration compared to emicizumab. And this drug has been shown to be well tolerated and is now in phase 3 clinical trial, and we are looking forward to have the data, this product available for the treatment of the patients. Another product which is now in phase 1 and 2 and is getting to phase 3 is NXT007, which I would say is a new generation of Hemlibra, which is IgG bispecific antibody working in a similar way of Hemlibra, but with much stronger and increased thrombin generation amount, and also improved clot formation and fibrinolysis, and reduce bleeding episode in the preclinical models that has been showed. And this could be a good important product in the future for reducing, eventually I would say, those patients that are not protected in emicizumab or even after small trauma. Finally, I think everybody's waiting for Innovate, which is an oral treatment produced by Novo Nordisk. Is a 2 VHH fragment of camelid antibodies, which make a small factor 8A mimetic antibody, and is actually achieved in a similar way in vitro effect of emicizumab. And this orally availability of the product is making it very interesting with a with a half-life of 113 hours, and everybody is looking forward to see the results of phase 1. We have concizumab, which is a high-affinity humanized IgG antibody against Kunis-2 TFPI, approved by both FDA and EMA for prophylaxis in hemophilia A patients and B with inhibitors adult. And in Canada and Japan also was approved for prophylaxis of a similar kind of hemophilia A and B with inhibitors. It's interesting because the injection is very easy, is a pen drive, similar to what you see in diabetes patient, but it's a daily treatment. And for this reason, the half-life of products is much lower, and in those that could be at the risk of thrombosis, it could be an interesting product. However, some thrombotic event has been seen at the beginning, but no fatal thrombotic event has been seen during phase 3 clinical trial and change of the dosage in Explorer 7 and 8. And again, we are looking forward to have more data on this product. Another anti-TFPI produced by Pfizer, mastacimab, is binding Kunis-2 domain of TFPI approved by the FDA and EMA for patients with hemophilia A and B without inhibitor, adult patients. This one, the difference to the previous one, is a weekly infusion, always subcutaneous. And even here, we have seen one thromboembolic event during the phase 3, and we look forward to have more data in terms of the post-registration surveillance to understand better safety and efficacy of this drug. And fitusiran, which is working in a different way because we have small RNA interferon therapeutic approach, which is downregulating the transcription of antithrombin and downregulating the anticoagulant activity of antithrombin. And this drug is interesting because it's subcutaneous 6 times a year, showed in both adult and children in hemophilia A and B with and without inhibitor. Very interesting data in terms of protection. And there was, at the beginning, even here, some thromboembolic event, especially when the antithrombin level was lower than 10%. And for that reason, the company declared we have to keep the level of antithrombin between 15 to 35%. And that's the reason the dosage of the product has been changed, and now we are looking forward to have again more data in terms of the safety and efficacy of these products for every 2 months treatment by subcutaneous infusion. And in the last part of my presentation, I want to bring the data on gene therapy. So we have seen factor 8 longer-acting product. We have seen the subcutaneous one, but there are few centers that are using gene therapy. And then, for example, in my center, I have used for 4 patients affected with hemophilia A. Gene therapy is a method of treatment that is different because we are introducing an exogenous functional gene into the target cells, in this case are hepatocytes, using a vector which is called AAV5 to introduce the gene of factor 8 or factor 9. You can see that several vectors has been used by the different companies, and not all of these clinical trials are active, and not all of them, they are available right now. You see that, for example, Pfizer, however, there was the results reported in different congresses. The collaboration between Sangamo and Pfizer has been terminated on hemophilia A, and right now we have only available the biomarine product, which is using the AAV5. And in terms of hemophilia B, several clinical trials have been started, but some of them have been stopped. Again, Pfizer discontinued the development of the commercialization of with Spark collaboration between Spark and Pfizer. And right now, the only product that right now have been approved is a CSL bearing product that I'm going to show you later. And recently we have heard that there is a Chinese AAV product available which has been approved. So right now, if I have to make a conclusion of what type of gene therapy is available for treatment of hemophilia A and B, we have Roctavian, approved by FDA and EMA, and we have Hemgenix for hemophilia B, approved by both FDA and EMA. The Pfizer one is not anymore available, and we have the new product which has been approved by Chinese regulatory agency, and the company who produced this product is called BBM HN901 and is for hemophilia B. So what is the results? The results for hemophilia A regarding the products that I showed by BioMarine using AAV5 with the usage of 6/10 to 13 vectors amount per cage, showing that at the beginning, the first year, the level of expression is getting extremely important, almost normal, and you have the reduction level after 2 years, and after 5 years, we still conserve about 18, more or less 18% of the expression of factor VIII. And this data is showing you the distribution of medium factor VIII activity of patients, 134 treated with the amount of the vector that I showed you. And here is interesting that most of the patients, they are having a level of expression more than 5%. And if you look on those that are less than 3%, are 26% of the patients. So we can say that about 74% of the patients have 76% have the level of expression higher than 5%. And what about hemophilia B? Hemophilia B CSL bearing product with 54 participants show a level of expression about around 40%, and in difference to hemophilia A, you can see that the level of expression is much more stable, and that's because the gene of factor IX is much smaller and the expression is much easier. And you can see that the level of expression, even 4 years, is remaining much higher to what is for hemophilia A. And here again is a distribution of the patient, and you can see that most of the patients are having the level of expression actually more than 40% after 3 years post-infusion. And in terms of the safety of the gene therapy, there are 2 sets of data that you have to consider. First of all, you have to see how many percent have significant increase of the ALT elevation, which means the liver toxicity eventually, or the sign that the liver just had the vector inside of the hepatocytes, but some of the hepatocytes might not be really happy about that. And why that is happening, there is a lot of study in terms of immunogenicity, in terms of the T-cell reaction, or in terms of the stress of the cells. But just a small amount of the ALT increase might not be a big problem, because I have seen in patients that could be solved. But if the level of ALT is getting much more, 3 times or 4 times more, you need really to pay attention on that and treat the patient with the immunosuppressive therapy. And long-term safety. Since more than 99% of these vectors is not getting integrated, so we don't have to be worried. But there is a small amount of vector, could be integrated, and that integration is extremely important to carry it and be sure that it's not activating any oncogene. And for that reason, every type of cancer that has been seen in those patients that have been treated have been characterized extremely well. And until now, there is no association between the cancers, the two cancers that has been seen, and the gene therapy. So in future, I think it would be very important, a very good safety evaluation and understanding how is the liver toxicity and eventually any type of long-term toxicity in our patients. So I think there is no doubt in none of the diseases that I work as a physician, there was such an extraordinary progress that has been seen in the last 10 years. And now I think it's very important to improve the quality of life of our patients, to use the less invasive and less, I would say, damageable or more safer product that is available for our patient. And to do that, the physician and patient, they have to know the efficacy and safety of every single product and have a very good chat and conversation with their patients and understanding which of these drugs could be suitable for treatment of their patient. So leading to a personalized medicine, reducing the number of the bleeding, and understanding as soon as possible the bleeding and treat them as much as efficacious possible in the future using these drugs. Thank you very much for your attention.
Thank you, Flora, for this excellent talk and very good overview of all the therapeutic options in hemophilia. I will have now a look to the Q&A. The first question is, why are non-replacement therapies not used for acute bleeding?
Correct. That is only for prophylaxis, and the goal is not having peak and trough and having a stable protection. If you are a patient with hemophilia, no inhibitor, you have to use factor VIII, but in a lower amount at the time of the acute bleeding. If there is a patient with inhibitor, they have to use the association with bypassing agent with a lower amount.
Thank you. And maybe related to the non-replacement therapies, we are now using imicizumab for already a rather long time in many patients. But now with the new product, the extra long factor VIII, the Altivoct, some patients are switched from imicizumab to Altivoct because the level of factor VIII is higher. With imicizumab, we always say it is an equal factor VIII level of about 20–30% that you have as coagulation activity. What is your opinion on that, to switch from imicizumab to Altivoct? In which patients should you switch or not switch to Altivoct?
I think it's very difficult for all the drugs, not only for the two that you have mentioned, to make a established rule of what is the time of the change of the drug. I think the emicizumab is a subcutaneous drug. I think with more or less level of protection of 10–15%, if you want to think about factor VIII, however, it's not factor VIII, it's a mimicking product, and definitely gave a very good efficacy, and in terms of the safety, especially in children, was fantastic. For the longer acting product, Altuvic, once a week, we have advantage of having the normal level almost in the first 3 days. If you have a patient with a very high sportive activity who wants to make sure that even in the trauma situation is not having any trouble, so then I think this kind of choice could be a good choice. And after 7 days, you have a level of 10%. And also, there is another point that is important. how the drugs is kept and the carrying the drug during the traveling. In case of emicizumab, you have emicizumab and you have to have something for the acute bleeding. In terms of the second product, you have one single product for everything. So these are, you know, the concept that's for some patients might be more important to have, you know, subcutaneous infusion. So then you leave it to the emicizumab. So I think it's very personal. That's the reason I think we have really to talk with our patients.
Yeah, okay, thank you so much. Next question is there any information on pain in administration of NTX-007, so the new product? Is it more or better or comparable to emicizumab?
That's very difficult to say because even in phase 1 clinical trial, if I'm not wrong, the numbers are very limited between, say, 6 to 10 patients are treated. So I think, first of all, we have to see the safety of the products and then efficacy of the product. Now, in terms of pain, I'm trying to understand with my patients whether the higher level of factor VIII or thrombin generation could solve the problem of the pain. Depends. If there is an active synovitis, you might need to use the anti-inflammatory to downregulate really the inflammation over there, but in meantime, to keep the levels higher. The new drug that you mentioned is more powerful compared to emicizumab and can give us a higher protection of the thrombin generation. But we have to see what's going to happen in the inflammation over there and how is damage already the joint and whether we have to really do something with a surgery or we have to do with a painkiller and anti-inflammatory drugs as well.
Yeah, thank you. Another question on emicizumab is in what circumstances is it necessary to monitor the emicizumab?
Definitely is important when the patient had efficacy, very good efficacy, and they start to see that the efficacy is not anymore there. And the bleeding is happening. At that stage, I think a very easy PTT assay could be done. And if the prolongation is a PTT is there, then I think it's very important to measure the concentration of emicizumab and anti-drug antibody should be measured. Fortunately, it seems that the number and the prevalence of anti-drug antibodies with the total functional activity is not so high. But I think every patient should keep attention. If they feel the efficacy is lost, then I think that should be measured.
Yeah, thank you. And then on gene therapy, question on gene therapy. The question is, in fact, how do you see gene therapy in under-resourced countries?
I think that's actually a very good instrument for that countries. I'm coming from last week trip in Pakistan, where the only treatment was cryoprecipitate. And I was really shocked to see the availability of all products we have here, and we don't know really what to choose. And over there are several patients that have no product at all. I think gene therapy could be an extremely well tool for this kind of patient. One single injection and for years you have expression. However, there is a problem of cost of these products. We need to see how in the future, and I hope these companies, they can really go to these countries and making some donation to World Federation of Hemophilia in the frame of humanitarian project, we can have the treatment of patients with the gene therapy.
Okay, thank you. Another question is regarding the anti-TFPI and antithrombin products. You talked on the two products and told us that you can use them in hemophilia A and hemophilia B. This is correct. The question was, in fact, will these be limited to hemophilia B? So I don't think...
No, because concizumab at the beginning has been started with hemophilia B in Canada. But now I think both drugs could be used, and I think how to use, which to use, we need to understand better anti-TFPI products. One is once weekly, the other one is daily, with a shorter half-life and easy administration of the drugs. So I think if you have a patient elderly with some, kind of risk factor for thrombotic event, you might want to choose the shorter half-life products, because if something is going wrong, you have the possibility to down-regulate the activity of the product. And for the once weekly products, of course, there is a longer half-life, and you can use it for both hemophilia A and B with and without inhibitors. And for fitusiran, you can use it for hemophilia A and B with and without inhibitor in both children and adults. And the results are interesting because, in my opinion, fitusiran has really interesting utility, because it's 6 times a year, and this product could be kept out of the fridge and it's easy to handle it. But we need, even there, to understand the level of antithrombin, measurement of antithrombin eventually, if there is any side effect, if there is any thrombotic event. So again, even there, I think assays is an important issue. We have to make sure that we are having a good assay and we are measuring correctly. And also we are making a good surveillance to understand more about the safety and efficacy of this drug.
Yeah. Thank you. Yes, some questions were indeed on the monitoring of the products. So for the lab, and I'm also a lab person, sometimes it's really difficult to find the good method to measure the products, and we have to have a diversity of assays available for each product that we have to measure in our patients. And even for some products, for instance, the concizumab, it is not very clear how we can measure the effect of it, because with the standard assays, PT, for instance, was suggested, but to my opinion, it is not useful to use a PT or a diluted PT. What is your opinion on alternative assays, for instance, thrombin generation assays? Can that be a solution for it?
I mean, you are more expert in assays compared to me, I would say, and you explain very clearly. I think for anti-TFPI, to my opinion, the only availability we have is a clinical manifestation of the patients right now, if you want to be scientifically correct. And thrombin generation, we need to collect the data and understand whether there is any correlation between the clinical manifestation of the patients and also the thrombin generation. I think there is good correlation between the amount of the product and thrombin generation. However, I'm not sure we are there with the TG results and the clinical manifestation of the patient. So I would not recommend to use that assay for the management of the patient. For fitusiran, as I said, the antithrombin, to my personal experience, is extremely really good correlation between the level of antithrombin and the clinical manifestation of the patient. However, it's important what type of the assay you are using over there. And this is something we need to standardize. For Attruvic, we need to have assay with one stage adopted to the products and not the chromogenic assay, because it's all out of their place. And even there, I think really we need to work on the laboratory aspect of all these novel drugs.
Yeah. And certainly with the newer ones coming, and we have to, in fact, permanently adapt our methods to the products that become available. But it's indeed important when we measure that we measure it correctly, I think. So
sorry, I didn't explain about gene therapy. And of course, gene therapy is a similar thing. We know that for hemophilia B, we have to use one stage, and for hemophilia A, chromogenic. But what are the differences between the different assays? This is something else that in the future we need to understand.
Yeah, still a lot of work to do on that point. Another question is the pain we already had. That is in fact the same question. The pain during administration. No, the attendee meant the pain during the administration of the product.
Oh, okay.
Of emicizumab.
Yes, emicizumab, I know that there is a portion, it was about 1/3 of the kids that they had the problem of burning or some feeling.
Yeah.
Some of them, they were transient, and after 2 injections, they are not feeling. And some of the patients, they continue to have it. In that case, most probably the parents were asking the change of the drug. But in my personal opinion, on almost all my patients that they are on emicizumab, they continued, and there was not a big issue over there, I would say.
Okay. And then another question is, what is the long-term impact of non-factor VIII replacement therapies on the bone structure of the patients? Is that known?
Okay, until now, I think data showed the role of factor VIII in terms of the bone structure and the activity over there. However, there is also data showing that the thrombin generation by itself could have a role over there. So whether the difference between non-replacement therapy and replacement therapy could have an impact in the structure of the bone, I don't think there are convincing data that there is a difference over there. But again, even here, non-replacement therapies, there are not so much years of treatment to understand. But definitely we have to follow our patient. And it's not only factor VIII, all other type of activities that factor VIII is doing, we need to look on it and understanding whether there is any difference.
Okay, thank you. And then a very practical question, an example of a patient that one of the attendees presents a 4-year-old child suffering of severe hemophilia A. He gets prophylaxis weekly, 500 international units, but he's still bleeding 1 to 2 times in the knee area. What would you recommend in that kind of patients?
But I don't know what type of drug, and I don't know if
No.
the patient has any inhibitors. I think, first of all, I think we have to see if there is any inhibitor and if the amount of the drug is suitable. And if he has still the problem of the bleeding, probably I would change the component of the treatment or the type of the drug that he's using.
Yeah. I will have a look at the... So we have all the questions. It's all on treatment, of course, because your talk was on treatment. But I have a little bit different question on the diagnosis, because you mentioned in the beginning of your presentation that the women with hemophilia A and also the carriers are underestimated. And probably this is, I think, also in hemophilia centers and so on, because we do not get the samples from that kind of patients, or we have a value that is near or even normal, in the normal range. So my question is, in fact, shouldn't we do more genetic testing to identify the carriers of hemophilia?
I think, first of all, we have to distinguish whether there are family history and the mothers are carriers or not. Then we are going to understanding what is the level of the factors. And then I think all moms, they have to be tested if they are carriers, and all sisters, they should be tested. And for that reason, we have really underestimation, because the attention of the families were always on the male hemophilic patients. And now I think we need really to also getting a little bit more attention to giving to the sisters and also to the mom. And we don't have to forget something else. We need also to consider the moderate and milds, first of all, to understand what is the rate of the bleeding in that one. And something else that for women with hemophilia properly, the rate of patients might not be similar in all over the board. Because if there is for example, if you move in developing world, there are in some region customary, they have consanguinity. Over there, you might have much higher number of hemophilia women patients that have not been diagnosed yet. And we need really to work on that group of women much more in the future.
Yeah, thank you. So I think we can end this very interesting webinar with a lot of questions, and I think we have learned a lot. So thank you very much, Flora, for this excellent talk. I also want to thank the organizers for their technical support, and of course, all the attendees that were present today. So thank you and have a nice day or have a nice evening. Thank you so much.
Thank you very much. Bye.